Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's membership, offering members special discounts, clinical resources, and unlimited free CEs, with information on how to join available at www.aacn.org/discoverAACN. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmitt.
Welcome to the Voices in Nursing podcast. This is Dr. Vicki Good, AACN's Chief Clinical Officer, and I'm joined by Brandy Pack, one of AACN's nurse content strategists.
Thank you, Vicki. I'm so excited to be here today and to dive into this conversation.
So February is Women's Heart Month, a time dedicated to raising awareness about heart health in women. And for me today, it particularly touches a heavy heart because I just lost a friend, a 46-year-old, to heart disease. And we're going to shine a light on a condition that goes unnoticed, which is peripartum or postpartum cardiomyopathy. This is a rare but potentially life-threatening disease that can occur during pregnancy or postpartum up to a year after delivery. Early recognition can save lives, and nurses really play a vital role in that process. Today's guest is one of our own, a critical care nurse and a regular podcast co-host, Andrea Schmitt, who bravely faced postpartum cardiomyopathy herself. She's here to share her personal journey and help our listeners understand what every acute and critical care nurse needs to know about this condition. So, Andrea, let's start first with your journey and your story. Take us back to the time of your delivery and your early postpartum period.
Definitely. I first want to say thank you for allowing me to share my story. I feel like it's so important for others to learn about it, especially during Women's Heart Month. So my story is a little long, but I'll try to make it quick. But basically, in 2010, I was pregnant with my first child. I was 41 years old. And at 33 weeks, I started developing symptoms of preeclampsia. And so in case people are not familiar with what those symptoms are, especially outside of the women's health arena, you get very hypertensive, you can see spots, there's a lot of other things. It can turn into something called HELLP syndrome, where you get liver problems, you get, hemolysis of platelets. Mine did not go that far, but I definitely had preeclampsia. I didn't realize it at first, but somewhere inside of me, I thought that I did have it. So, of course, this was a weekend, and I thought I'm just going to wait all weekend long. And then when I got to work, given that I worked in a critical care unit and I was the educator, my office was across from one of the patient rooms, and I went into an empty patient room and I put myself on the monitor and took my blood pressure, and it was 140/90 first thing in the morning. And I thought, oh, I must just be nervous. This must just be nerves. I'm going to go back and check it later. Like, I was in total denial. And so went back an hour later, and it was like 150/92. And then another hour, it was up in the 160s. And I was like, I don't think this is right. So I wound up calling my OB. They said, oh, yeah, come on over to labor and delivery. I was in such denial. I told my boss, I'm leaving. I'm going to go get my blood pressure checked. I'll be back in an hour. And she was like, are you sure? I was like, oh, yes, I'm totally sure. That's fine. So they put me on the monitor in labor and delivery. Everything was fine with the baby. He was doing great, but it was me. And at one point, the doctor walked in and she was like, I've been watching you for the last 2 hours, and your highest blood pressure was 210/120. And I was like, what? Oh my goodness. So the next thing I know, she's like, nope, you're going on drugs. So they put me on labetalol. The nurse came in with an injection of surfactant for the baby's lungs, because she's like, we are taking the baby in 2 days. And I was like, oh my gosh, like everything hit me so fast. And I think what really scared me is that when they came in to do my deep tendon reflexes, which ICU nurses, we don't do that, right? But they do that a lot in labor and delivery. And I had very hyper reflexive deep tendon reflexes. And I also had something called clonus. So if you're not familiar with that is, you basically, you dorsiflex the foot and you push against it. And if the foot bounces, it's a sign that you have neurologic irritability going on. And so that makes your threshold for having a seizure much higher. And so I was pretty sick, but didn't know it. And I think in that regard, ignorance was bliss because I probably would have had a major freak out. So then, anyway, they put me on magnesium sulfate, and the fluid shifts that occur from that, I don't think I realized how intense that would be. And I wound up putting on, I think, close to 20 pounds of fluid in 2 days just from the fluid shifts to the point where I didn't recognize my own feet. And I wind up delivering the baby. So he was born at 33 weeks and a day, no, 33 weeks and 2 days. And he was doing great, other than needing some support. I thought I was doing great. I get moved down to postpartum. I'm able to go see him. And then I get discharged 2 days later. So I went home and I noticed that my ankle still seemed really swollen. And when I went back to visit my child, the nurses were like, "Wow, your feet are so swollen." They're like, "You had a C-section, right?" And I was like, "Oh yeah." They're like, "See, oh yeah, everybody with C-section, their feet look like that." So in my brain, I thought this was normal and I was supposed to look like this. And I was craving all this salty food that I did not eat while I was pregnant. So I was eating things that were salty. And within 2 days, that at night, I laid down and with my ear pressed against the pillow, I heard water in my chest. I heard water slashing up and down. And I was like, oh, that's weird. And the nurse in me was like, I've never had a baby before, but I don't think that's normal. And I just, again, was probably in denial. And I was thinking, okay, let's wait it out one more day. Well, the next night I could not lay flat. So I had orthopnea. And I'm like, But what do? I push it one more day. And by the third night, I had to sleep more sitting up. And I felt like I had to keep taking deep breaths. So I went into my OB. And in my brain, I was like, it's probably a PE. That's what I kept thinking. It's probably a PE. I was not thinking heart failure. And I got sent to the ER, and my x-ray showed that I had bilateral pleural effusions, bilateral pneumonia, and based on whatever they heard in my heart, they brought in echo, and I got diagnosed right in the ER with postpartum cardiomyopathy. My ejection fraction in my heart was 35%. So it was an extremely, extremely scary situation. I remember feeling absolutely hysterical. Like, how could this be happening? I did, waited so long to have a baby, and now I just had him, and all the feelings. You're going to die. It was very frightening. And so with treatment, number one being Lasix, I lost 8 pounds of fluid in 24 hours and then got put on every cardiac medication known to man, it felt like. And so that is my long story, very short. Just so everybody is aware, I have recovered. I recovered in 2 years total. My ejection fraction with proper treatment went back to normal, and everything is good now. But it was an extremely scary time, and one that I think really warrants a lot of knowledge from any nurse in any area.
Andrea, that is so scary. And I feel like true nurse in you decided just to wait it out, or just it'll be fine. Um,
We've all done that.
they were
Yes.
one more day, right? One more day.
Yeah.
So many of our nurse colleagues are familiar with cardiomyopathy in general, but like this postpartum and peripartum cardiomyopathy maybe is probably new for some listeners. So how is PPCM, also known as postpartum cardiomyopathy, similar to other cardiomyopathies? Like what makes it unique? Is it time period or what other things are unique to this?
For sure. So there are definitely similarities and differences between regular cardiomyopathy and postpartum cardiomyopathy. But first, I want to circle back on something that Vicky said about how it's rare. It is such a rare condition, a rare form of heart failure. Only anywhere between 1 in 1,000 to 1 in 4,000 women that have live births in the US are affected each year. So it's a very small amount of people. So the similarities are that it involves heart muscle weakness, right? So there's a reduction of the ejection fraction, you have increased preload, you have your LV, your left ventricular end diastolic function is increased due to systolic failure. So the ejection fraction's around, well, it's going to be less than 45% for the diagnosis, and it can be with or without dilation. So those symptoms are going to be the same, and same thing with like shortness of breath and fluid retention, etc. What's different is that it's a rapid onset. It's associated with either the pregnancy or the postpartum phase. And what also makes it different is you may not recover from traditional heart failure, but there's a huge potential for full recovery with postpartum cardiomyopathy. And the main difference is the underlying pathophysiology of what's causing this versus what causes traditional cardiomyopathy.
So, Andrea, building on that, are there specific risk factors for developing postpartum cardiomyopathy, or is it just a matter of chance?
There are some specific risk factors. I think the problem is that the underlying cause is not 100% yet understood. There are some studies that do suggest that it could be a viral illness that precipitates it. They're finding more and more it's more hormonal imbalances that damage the vasculature, and that's the leading theory currently. And causes inflammation. Some people who may have maybe an undiagnosed issue with their heart could be increased blood volume from the pregnancy or an autoimmune disease. So the ones they know for sure are advanced maternal age, so 35 and older. Those are the ones they see the most. High blood pressure. So whether you have chronic hypertension to start with or preeclampsia is definitely associated with the conversion to this, or gestational hypertension. Obesity, pregnancy with multiple. So if you're twins or more, maternal cocaine abuse, and then if a woman has been on tocolytic therapy, so that is the medication they use to suppress contractions, so like tributaline, if they're on it for more than 4 weeks, it can also be a risk factor. And then lastly, African American women have close to double the risk of a non-African American, and they don't know the reason why. So those are the typical risk factors and the potential causes. And unfortunately, even with the research, they still don't entirely know the true cause.
There's so many things to be alert to. But what about those clinical symptoms? I know you mentioned that you had a C-section and your little feet were no longer there and full of fluid.
Yes.
So my knowledge of postpartum is limited, so I don't really know what normal postpartum change is, but it does sound like, you went in and they're like, oh, you had a C-section, it's okay. Like this is a common thing to see. So are there clinical symptoms that like nurses should be alert to? And like, how is this typically diagnosed?
So yes, for sure. So it is hard because you do swell. You swell with being pregnant, right? And you can swell from fluid, just from anything that they're replacing with, during the pregnancy, especially if you have a C-section, right? You're getting some volume. And, but I think what's hard is that because of the time period in which it can occur. So as Vicky mentioned at the beginning, it could be like 5 months, 1 month, up to 5 months, even up to 12 months post-delivery. And so the further you get from the delivery, the bigger the disconnect is. We don't often go and ask people, when did you deliver? If they come in with the baby in their arms, you might link that. But if they delivered 9 months ago and they're coming in with swollen ankles or they can't breathe, it's hard to make the connection there. easier when you've just delivered. So mine was within a week. And typically, most people that are reported are within the first month after delivery. But I think, you know, this is what we have to sort of teach nurses, doctors who are not OB is having this high index of suspicion if the patient was pregnant. And so, they look at routine lab work. They want to rule out other things. And that's what we do. We can't sort of sit here and think, oh, it's just asthma or it's just something else. We need to really make sure. And so, really, a chest x-ray, really looking for cardiomegaly, pulmonary edema, but echo is really the primary diagnostic study for this. So, one thing I failed to mention was that earlier in my pregnancy, I was having these periods of feeling like my heart was racing midday. And of course, the nurse in me, I put myself on the monitor. My heart rate was like 140. And I was like, what is going on? And I had an echo while I was pregnant, and it was rock solid normal. So I did not have any problems while I was pregnant. What it was attributed to is that the way my son was laying in me, he was compressing my kidney all day. And when I would lay down at night, he would be off my kidney. And so then I was having increased urine output all night long and not replacing my fluids. So it was more orthostatic changes that were causing the increased heart rate. But I think in this instance, it's so important if you have somebody who is either pregnant or postpartum to make sure whatever kind of doctor it is, if you're the nurse, suggesting maybe you want to have a conversation with the OB just to make sure there's nothing going on. Because if there is something going on with the heart, you've got your OB, it needs to be a collaboration. Bring in cardiology once we start narrowing down the diagnosis. Other things, EKG abnormalities, you could have non-specific changes, but SVT, sinus tach, all because of the increased volume. Some people can have a fib, which is unfortunate because then they're now hypercoagulable already from being pregnant or having all this extra volume, and they're more likely to have a stroke. It's just this nasty chain of events that can really occur. And then your traditional symptoms of heart failure. That's really, really it. The shortness of breath, pedal edema. And I think that's the one that gets people because they assume you're going to be swollen. But I think the biggest questions to ask is about the sleeping at night. Are you having shortness of breath when you lay down? Can you lay flat or do you have to sleep on pillows? Like we would ask a traditional person with non-pregnancy who has heart failure. And, pregnant women or recently pregnant women also can have those periods of shortness of breath on and off just from all the volume. So how do you differentiate, right? So it's how long is this going on? Is it getting worse? And so that's really something that needs to be looked into. Other symptoms can be a dry cough, lightheadedness, palpitations. But again, you have palpitations when you're pregnant from blood volume. So it's really diagnosis of elimination in some regards. Assessment findings, though, a lot of times you can get from extra volume at S3 heart sound. So you get an extra heart sound. Sometimes people can get a new murmur. But if somebody comes in severe distress, you're going to see the same symptoms of acute respiratory failure and potentially cardiogenic shock.
I just still can't believe that you had an echo and it was fine. And then all of a sudden it like wasn't fine. So
Neither
I know
can
you
I.
like
Neither
I was
can
gonna
I.
ask like did you have a heart condition before? It doesn't sound like it though. So it's just wild that, this kind of happens. So I know you mentioned kind of LASIK. So what kind of treatment, does this involve? I know we had spoke previously about maybe stable versus unstable cardiomyopathy in this case. It sounds
Yes,
like yours was stable. Maybe didn't feel
I
that way, I'm sure,
was.
at the time, but how did you treat this?
So diuretics, obviously, number one, and then getting that blood pressure under control. Because even a week after discharge, I was taking like a small amount of labetalol, and when I got to the ER, my blood pressure was still in the 170s. And I remember being given hydralazine, and the ER nurse was like, I don't know how much more I can give you. I'm so afraid I'm going to bottom out your blood pressure. And the doctor was like, no, trust me, it's going to take a long time. Give it. And I was like, okay, you know, but beta blockers, that's going to be one of the main things because you really want to reduce the workload on the heart, reduce the oxygen consumption, and prevent the remodeling of the heart in a negative way. So the beta blockers help with that. If you're not pregnant, then an ACE inhibitor or an ARB, so an angiotensin receptor blocker, that's really going to be postpartum only because there's too much risk to the fetus if you're pregnant. And then depending on your EF and how low it is, they could even do implantable cardiac defibrillator, which
Wow.
thank heavens I did not need. Now that's your stable patient. If you're unstable, you're going to look like a classic patient with hemodynamic instability. So you could present with low blood pressure, high heart rate, look like cardiogenic shock, and all the clinical changes that go along with that. So pallor, skin moisture, you know, some people look ashen, decreased urine output, definitely may require, well, no, it will require ICU if you're in cardiogenic shock. Inotropic therapy for those patients, so your dobutamine, and maybe pressors, both. And then if it gets bad enough, mechanical circulatory support. So whether it's a balloon pump, an Impella, you know, I think the big thing is, you know, these patients are at really high risk depending on how low their EF gets. And some women wind up on a transplant list. It can really go downhill very, very quickly. So I feel very blessed that my ejection fraction was only 35%, because this, you know,
That's not
it's
enough.
very scary.
35 isn't enough, just so you
No.
know. It's
Well,
not
it's
enough.
not, but better than 5%, you
So you
know,
had
and
your a C-section. In the C, you had the C-section because of your blood pressure.
no, I actually had my C-section because my son was breech.
Oh, okay. So like, but they took him out a little bit early. It had nothing to do with your heart at that time when you had the
Correct.
C-section.
Correct. He was breech. Like he actually was head down when I got there, and then he flipped himself.
He wanted to turn
So
over.
they did a C-section, and you know, in retrospect, we don't know when this started. So I kind of am glad because I can't imagine what if I did have heart failure at the time, what would have laboring been like? I don't know.
Yeah, that was kind of my question. Like, does the treatment change if, the baby's still in there? I'm assuming if your EF got worse or they would take baby out, like to
Immediately,
protect you
yeah.
and the baby. So I didn't know if maybe that was the reson why the C-section came, since he was just a little guy. Um, but it just sounds
Yeah,
like it's kind of case by case for
it is.
those treatments. So
If mom is pregnant and things are going south, they're going to take the baby immediately, but that was not true in my case, which is good. The one thing I did not mention is that, you know, there is a risk of relapse. So if they fix you, there really has to be a conversation about future pregnancies with a doctor, and talk about, you know, family planning and looking at your age. If you had preeclampsia once, you're likely to have it another time. If you had cardiomyopathy once, if they fix you, you could still have it a second time and it could be worse. So that's definitely a conversation that has to occur, and each patient has to evaluate their own risk and comfort level if they choose to try to get pregnant again. And that's something that the entire team needs to be aware of because if a woman had cardiomyopathy once before and she does choose to get pregnant, that person needs to be monitored during their entire pregnancy. And the whole team in the hospital should know what's going on because, and we did that at our organization. If we had somebody on our radar and they would be doing echoes serially on them, and we saw that their ejection fraction was getting lower and lower, that is you're going to deliver and are you going to wind up in the ICU, depending on how bad it is.
So I know I cared for patients almost 40 years ago, most of them in cardiogenic shock, because I started my nursing career at a large city county facility. So we got a lot of OB patients there. And when they when they weren't doing well, they wound up in my ICU. I'm sure that treatment has changed through the years from when I treated them, but also what's on the horizon? Is there active research on this disease and, potential new treatment plans coming out?
So there is some promising new treatments as they are researching more and more what the potential causes are. They're looking at prolactin as being a contributor. So obviously we know we make prolactin when we're pregnant, right? Because that's what helps us with breastfeeding and lactation. And so what they're thinking is that the breakdown of prolactin, when it starts to break down, it is causing damage to the vasculature and heart muscle damage. So there's a trial right now called Rebirth that's happening. They're currently enrolling patients and it's set to conclude in 2028. And it's looking at the use of a medication called bromocriptine to inhibit the breakdown of prolactin because they believe that's pro-inflammatory. So right now it's proving to have some successes. So that's where they're at right now, and possibly looking at some anti-inflammatory type agents. I think the thing that people need to understand though is once a woman has had postpartum cardiomyopathy, you want to think of this as, unfortunately, a window to the person's cardiac future because the damage may permanently reside in your vessels, and then in the long term, you have more risk of having hypertension and cardiovascular disease as you age.
Wow. I mean, pregnancy just, we give life into the world, but apparently it takes a lot out of our hearts, in more than one way. So it doesn't
It
sound like we'll
does.
see those, until months after the delivery. It's a gift, but what kind of, it's taken a toll on your little heart there, that's for sure. After all of your story that you've told us, which is still, I had no idea. Just as one of your colleagues, I feel like I would have known, but I did not. So I've learned so much today. After all of this, though, and knowing kind of what you do now and all of the learning that you've done, like what is your key message to these listeners to take away with them?
I have several, but what I would say is, as a nurse, regardless of what department you work in, if a woman is pregnant or if she's postpartum, I think it's important to know if they've had a baby in the last 12 months. If they're coming in with any kind of symptoms that look remotely like they could be heart failure, I think it's really important to maintain a high index of suspicion and not assume it's something else. Unfortunately, I had a patient who presented to the ICU with a cardiac arrest, and it turned out she had postpartum cardiomyopathy. She had wheezing for 6 months, and they just kept saying, it's asthma, it's asthma, it's asthma, till she collapsed on the floor in the kitchen and was brought to the emergency department. And unfortunately, once they realized and did the echo, her ejection fraction was 5%. And there was no connection made with her doctor. And so I think it's important that we continue to keep this in the forefront of our mind that this is a possibility. It's rare that women can go into heart failure, and do the workup, do your proper assessment, listen to the breath sounds, look at their feet. Are they swollen? And rule that out. And if everything is good, then you can proceed with a regular diagnosis of something else. But we don't want to miss that because obviously there's a lot of treatment that needs to occur to prevent them from getting to a place where they wind up on a transplant list.
Well, Andrea, this has been fascinating and so grateful for you for sharing your story. I mean, pregnancy-related cardiomyopathy may be rare, but its impact can be profound for these individuals that contract it. Awareness, early recognition, and interdisciplinary care is key to saving lives. So thank you so much for sharing your story with us and the listeners today.
Thank you for allowing me to share my story. I just want everybody to learn from it and prevent another woman from having a major complication.
Well, and thank you to all of our listeners for joining us on today's episode. As always, we welcome your feedback on this episode and any ideas for future episodes. Please send your feedback to podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's membership, offering members special discounts, clinical resources, and unlimited free CEs, with information on how to join available at www.aacn.org/discoverAACN.